I'll just be bold and say I don't think AI is ever going to be sentient. I don't think that that's a thing. Like we're just talking about a math. We're talking about algorithms running in the background based on patterns that they find in data. And at the end of the day, these algorithms aren't making decisions. They don't have agency. They just blindly follow the pattern. So there's definitely there's an opportunity there for us to significantly automate that process so that physicians don't have to think about that stuff. They shouldn't have to think about that stuff, right? Even if you go to school to become a really good medical coder, what you're learning is the combination of codes that Bill
Codes,
wanted.
right? It's
But you're
not.
still not a doctor. Go find the technology partner, because that combination of the right technology partner and the right medical partner equals AI Medica or the equivalent, right?
Right.
And that's where we've really found a ton of success.
Welcome to Digital Health Transformers, the podcast where we explore the dynamic world of healthcare innovation, one conversation at a time. I'm your host, Bryce Barger, and today we have an awe-inspiring guest at the forefront of transforming the healthcare landscape. Join us. Okay, here we go. Joining me today, guys, is Jordon Ritchie. He's the CEO of AI Medica. He is a software developer with a PhD in informatics and data science. He's focused on optimizing electronic health records to improve patient care and decrease physician burden. AI Medica is a digital health company. They leverage the power of AI and artificial intelligence to unlock the true potential of EHR data. It automates physician workflows and deploys evidence-based risk scores to improve patient care. With a focus on improving patient outcomes, AI Medica aims to increase access and research data to point of care. So in this episode, we'll delve deep into Jordon's journey, how AI Medica is changing the game, and the difference it's making in patient and in providers' lives. Thank you for joining us today, Jordon. How are you?
Great to be here, Bryce. I'm doing really well. Thank you.
So to kind of get started here, could you tell us a little bit more about your background, kind of how you decided to kind of get into the health tech entrepreneur world, and kind of what that journey looks like for you?
Sure. Yeah. I originally told myself that I wasn't going to do this. I started out kind of in a life science track. I really thought that I was going to become a researcher, and I was in molecular biology and specifically in genetics and genomics. I was pushing pipettes in labs and doing experiments, and I was introduced to bioinformatics briefly, and I was initially fascinated by it. I kind of kept pressing on that vein, and it grew and grew, and I eventually started working for a small startup that was doing it was a genomics startup. They were looking at trying to identify rare diseases using broad genomic analysis. They had a really cool platform. I learned, I was in the startup, you wear every hat imaginable. So I was learning a ton outside of the science itself as well. And unhappy ending there. Company went under, but learned a ton, and that kind of set me on this path away from sort of the research realm. I kept going down the software development route, and I really wrestled with whether I wanted to really continue down that research if I wanted to go back to get an MD, become a doctor. I really got interested in health and the intersection of technology and healthcare, and ultimately decided to, after working as a software developer for another year or two, decided to go back and get my PhD. And so I went to South Carolina, to the Medical University of South Carolina, and studied biomedical informatics and data science. And there I discovered electronic health record systems, where there's an enormous gap, both technologically and in data and the use of data in healthcare. And I don't know, it spoke to me. It just seemed like my place. It seemed like where I wanted to add value. And graduated and connected through a VC firm with my business partner, Dr. Adam Robison, who had founded AI Medica. Amazing. He's an amazing guy. He's one of those guys that operates and at such a high level of efficiency, can get so much done. And anyway, he started this company, but he's also still being a doctor, and
Right.
and he's like, I need technology. I need somebody who can come help me run this company. So I said, well, I'll bring the technology. He said, I've got the medicine. It was a match made in heaven. We've been working together ever since, and that's how I got into where I am.
So you also did some missionary work in Thailand, is that correct?
I did, yeah. That was a
What was that
huge
experience
part.
like?
Yeah, huge part of my genesis, and really turned me into it. Made me a much more compassionate person.
Yeah.
Broadened my perspective, helped me see the world very, very differently. So I'm a member of the Church of Jesus Christ of Latter-day Saints, and we serve missions. We go, for 2 years. We put our paperwork in, and the church leadership makes a decision about where we'll serve for the 2 years. And I received a call to go to Thailand, and I was all over Thailand. I spent almost a year in Bangkok and 6 months up north in Chiang Mai area. Then went out to the northeast and the Isan, and it was transformative. We learned the
Yeah.
language. We lived much closer to the people than if you go vacation type of thing. You kind of live go stay at a resort or something like that. We lived in an apartment in a neighborhood with a whole bunch of other people type of thing, and boots on the ground, and we got to see the world in a very different, for a 19-year-old kid too, is
Right.
super eye opening. To a totally different
Yeah.
experience. I participate in lots of different things and serve in lots of different ways, and really kind of get out of myself. uh,
Yeah.
you know, recognize too what I have and what I've been given and blessed with, and have an opportunity to give something back. It was hugely transformative for me. Really changed my approach to my career, my business, and who I wanted to be, and what kind of projects I wanted to be involved in, and how I wanted to uh, lead my life.
Yeah, for sure. That's definitely, I could only imagine how rewarding that would be to be able to go over and experience the different culture, and kind of like you mentioned, when you go as Americans and you go over and experience kind of some of the other countries, you do get that resort feel. But when you get to kind of dive deep into the true culture, the streets, and kind of get fully immersed in their culture is so rewarding. And then to be giving back in a missionary type state is fantastic. So thank you for sharing that.
Yeah,
So
yeah.
kind of to get back to the technology side of stuff, I know nowadays, of course, everybody is very interested in AI, artificial intelligence, AI. Let's go! Oh my gosh,
Yeah.
and kind of the potential that it has. How do you think AI is going to kind of affect the healthcare industry in the next, 10 to 20 years, or
I think it's
really
gonna.
even more than that, 5 to 10 years, I would say, of how
I,
things are going?
I think it's going to transform it. I think, like any really exciting technology, there's tons of transformative potential here, and we're seeing a ton of that transformative. We're realizing that transformative potential, but I also think there's a lot of froth. I think that there's a lot of excitement that's misunderstood, and that's also
Sure.
very common. New technology. There's once people get their hands around a hammer, everything becomes a nail.
Yeah.
And we do have some of that. And so I think on the one hand, there's some tasks and jobs that AI is very, very well positioned to help automate, very, very well positioned to help expedite and do. There's other jobs and tasks so that people are very excited about AI doing, that I don't think AI is going to be very effective, and isn't going to have exactly the kind of impact that people are looking for. I come back to this all the time. AI is just math. It does imitate what looks like intelligence, and people get really hung. I see an article a week about AI becoming sentient, and I just
Yes.
and I just wrote an article about this too. I'm looking for some places to get it published here, and there's a look for that coming out soon somewhere. But I just wrote an article about this, and it's not like I I'll just be bold and say I don't think AI is ever going to be sentient. I don't think that's a thing. Like, we're just talking about a math. We're talking about algorithms running in the background based on patterns that they find in data, and at the end of the day, these algorithms aren't making decisions. They don't have agency. They just blindly follow the pattern. They're dispassionate, right? They're going to spit back to you whatever you give to them in the first place. And so uh, I think that in some industries where you can give really, really, really good data with solid patterns in the data, you're going to get a great application of AI. That's why AI is working so well in imaging, because when you give images to an algorithm, each image is a complete picture. It has all of its pixels, right? And it's easy to spot a picture that's missing pixels. And if you give an AI algorithm pictures that are missing pixels, your output's going to be missing pixels, right? Or it's going to have pixels in weird places. And so, something like images does really, really well. But when you take data that's incomplete, right? Like a patient record, for example, patient records are not complete pictures. They're missing enormous chunks, right, that are siloed away in different health systems. Even if you took all of a patient's data from every hospital or doctor's office they'd ever been to, and you managed to coalesce that all into one record, it would still not be a complete picture of the patient. And it's the idea that we're going to throw all of that incomplete data into an algorithm and then expect it to produce outputs that doesn't have holes, that doesn't have errors and make mistakes. That doesn't work that way because it can only follow the pattern, right? And so stuff like that makes me really nervous around certain applications of AI because, again, it's just hammer and nail. Everybody's swinging this AI hammer at whatever they can. And if you hammer in a nail, it works really well. But if you try and hammer in a screw or a bracket or something that's not a nail, right, it doesn't work so great. And so I think there is a lot of froth. I think there's a lot of misconception about what AI is, how it actually works, how it's actually deployed, and how to control the types of outputs and outcomes that you get with your AI. I think there's a lot of growing that the general consumers of AI need to understand as we move forward that will help a great deal.
Sure. I think kind of to, as you said, with anything new, there's that learning curve and there's that um, general excitement where people just rush in without doing have the proper knowledge, the proper research. So I agree with that 100%, Richie. Um, I think that's fantastically well said. So why
There's another side to this too that I should probably highlight, and that is this
yeah.
fear that there's and we should just disabuse anybody who may still be under this impression that AI is going to somehow start replacing people.
Mm,
In a big way. And it's true that there are some tasks that AI is well suited to do really, really well, but
yeah. Help
it's actually
automate.
it's a lot more difficult for AI to replace people than I think people think.
Mm,
And there's something called the fundamental theorem of biomedical informatics. It's posited by Charles Friedman that says that
yes.
a computer um, plus a human, right, is better than a human or a computer by itself.
Right.
And the reality is that AI will always need to be paired with humans.
Mm,
Period. Recently, I read a quote recently from somebody at the American Medical Association. He said something like, I'm convinced that computers will never replace doctors, but doctors who use AI will replace doctors who don't use AI." Right. The point is that AI is going to become a companion tool, not a replacement solution.
right.
Um, and especially in medicine. And we're seeing this even with AI Medica. Our aim is not to replace the doctor. Our goal is to augment the doctor, right? Is to
Correct.
remove tasks from the doctor that the doctor either doesn't have time to do but should be doing. Usually tasks the doctor wants to do but doesn't have time to be doing. Or to another way is speed up and enhance doctors' ability to care for patients. There's another iteration on that theorem of biomedical informatics from Charles Friedman by another guy. I forgot his name, but they did a really interesting experiment around chess using these AI algorithms where they've got some AI algorithms that play chess really, really well, right? And they did this experiment where they said, all right, we're going to have some grandmasters operating alone. We're going to have some grandmasters with a single AI resource. We're going to have some AI resources playing by themselves, and we're going to have some other chess players playing with a bunch of AI resources. and we're going to do a tournament, right, and see who wins.
Right.
And interestingly, the team that won was an amateur chess player who was using multiple chess algorithms as he was playing. And that amateur chess player with multiple AI algorithms ended up beating the grandmasters, beat the grandmasters who were using a single AI resource, beat the AI resources, right? And so what we really learned there is that and they really expound on this, and they say, look, a weak human using many AI resources and a good process is better than a strong human working with a single, even many AI processes and a weak process, right? And so there's something to be said for the power of combining a great process with strong
Right.
AI algorithms. You can turn a crappy doctor into an awesome doctor.
Fantastic one, right?
Right.
Yeah, yeah, and I
But the
love
point
what
is
it.
it won't replace the doctor, right?
Yeah, and I was about to recap. I love what you said there, where you said, "Listen, AI is not meant to be a replacement solution. It's meant to be a tool." And I think that is that really hits the nail on the head of what how AI should be looked at as a hey, because you're right. There's always going to need to be those checks and balances. The AI will never know what it's not input, what's not input into it. So I think there's always I agree with that where there will always need to be the I guess to get the full scope and to get the everything out of AI, there will always need to be that human input and that human use of it to really put it to its full use. So
Yeah.
I love what you said that. So I know AI Medica is focusing on EHRs and has a
Hmm.
big focus on EHRs. Why EHRs? Why did AI Medica choose? I obviously know there's a huge gap in the technology of EHRs. Is that the main reason, or were there multiple reasons of why AI Medica chose to focus on EHRs?
Well, yeah, Medica was founded by Dr. Adam Robison, who, like just about every doctor who's ever interacted with an EHR, experiences significant pain in the electronic health
Yeah,
record system. You've seen those billboards that say something like, I love back pain, said no one ever. Yeah, that's kind of how doctors really. It's like, I love EHR, said no doctor ever, and that's a terrible loss. Like EHRs were supposed to be this huge improvement on how we manage our
Mhm.
medical data, and it was supposed to provide enormous benefits from management standpoint, documentation standpoint, from treatment and clinical research and all these different things. The reality is that it hasn't delivered on any of those promises, and it's not a technology problem. It's a business political problem. And by saying it's not a technology problem, what I mean is that as a we understand how the technology should work to provide those values, but
Right.
politically and from a business perspective, the technology hasn't been implemented that way, and we're in that space. EHRs are leveraging all kinds of bad practices that have been that aren't in use in any other industry that's doing amazing things with large amounts of data. You think about what we're accomplishing with online banking and with air travel and with
Yeah.
e-commerce and with all of these large industries that are leveraging big data and access and security and all these different things that matter. We're not doing that stuff in healthcare, not with EHRs, not the way that we should. And it's not because we don't know how, and it's not because we can't. It's just because those who are in power have chosen not to for
Yeah.
various reasons that are unfortunately selfish and not in our general interest. But there have been positive steps forward recently with legislation come out from the Office of the National Coordinator of Health Information Technology to open up EHRs and mandate adherence to common data standards. This is the substitutable medical apps and usable technologies on fast healthcare interoperability resource, also known as Smart on Fire,
Yeah.
that makes it easier for defines a common way for data to be exchanged between health systems, promote interoperability, and start tearing down some of the barriers to entry for innovative startups and companies so that they can get in with the data and actually produce value in a technology environment that so far has has arguably underachieved given its
For
potential,
sure.
right?
Right, and I
So
think and I think people in the everyday world who not in healthcare technology, I don't think they fully understand like the benefit of having a truly effective EHR. and what that can do to patient outcomes and what that can do to um, just so many things around the board. So I guess, um,
No, absolutely. I totally agree. And
you know,
and part of the reason
yeah,
that part of the reason that the EHR was such a focus initially was because for Dr. Robinson, it's he spends so much time. He's like, I got to make this
yeah,
better for myself. And so
right,
there was a very eat your own dog food esqueness. That's not very eat your own dog food vibe to how AI Medica
yeah,
became. And for me, I'm not a doctor. I'm not that kind of doctor, right? I don't see patients, and so for me, it's like I'm looking at this more from. I think that EHRs could be the equalizing force for patients in healthcare. We always talk
hmm
about, it's healthcare is about the patient. We got to engage the patient. We got to get to the patient. We got to help the patient. And for all the talk we have about the patient, there's nobody more disenfranchised in healthcare than the patient. They're
right,
so removed from their healthcare, and the biggest reason for that is because it's data.
hmm
Patients are completely removed from healthcare because they don't have access to their data, at least not easy access to their data.
not
I mean,
easy access for sure.
you think about what we do with our money. You can access multiple
Mhm.
financial institutions and link them across to each other super
Snap of a
simply.
finger. Yeah.
Yeah, because the finance sector has adopted application programming interfaces, and they have avoided the disincentive of hoarding data because the end user, we won't tolerate that, right? We won't use their services
Yeah.
if our money can't be shared. And so it's like, and so that's why the security and the HIPAA compliance and or not the HIPAA compliance, but the security argument, the privacy argument that no
hmm
data should be shared doesn't hold water, right? Yes, I'm all about HIPAA, I'm all about privacy, I'm all about security, and we adhere to all of that, and we're very careful. We don't store any PHI. We're we do everything on the up and up. Everything's above board, um, and we need that. That has to be. But the argument that a lot of these big EHR players have pushed is that because of privacy and security, there can be no data access and no data sharing. That's a lie. It's just not
Yeah.
true. And if you dial security all the way to 100%, you don't have a product, right? If you can't
Yeah.
access the
How do you
data at all,
innovate?
you can't do anything, even
Yeah.
from a user standpoint. And that's what we're seeing. Doctors can't really do anything with the EHR that's useful clinically. Patients
Mm.
can't do anything with the EHR until very recently, and still kind of coming into being. Patients had to pay and wait for a long time to like have a PDF of their record printed out into like a bound book. Like, it's
Yeah.
crazy what some of the practices
It's
here. So
yeah. With the technology we
I
have, it's what are we doing?
exactly.
Yeah.
Exactly. I think there's a huge opportunity for the EHR once it's opened up, and once we can really optimize it and turn it into what it should have been all along. I think there's a humongous opportunity to not only transform the technology in a way that significantly benefits the way doctors treat patients, but also to engage patients where healthcare happens. Dr. Robinson says this all the time. Healthcare happens in the home. The 40, or the 20 years or 30 years that lead up to a chronic disease, that happens in the home. That doesn't happen in the
Mhm.
hospital. They just end up in the hospital as the result of those 20 or 30 years, and we're
Right.
not reaching patients there, right? And the way to do it's with
Mhm.
data.
Yeah. So can you kind of elaborate more on the impact of the dynamic risk scores and kind of how those are automatically generated based on the patient's problem list with AI Medica?
Yeah, sure. So we build a clinical decision support tool as one of our products that is aiming to simplify the workflows for physicians who are beholden to hundreds or even thousands of potential medical risk scores that require input from data in the EHR, and then they've got to know which scores map to which patients, and they've got to manually hunt down the data, plug it in. We're talking about lab values and vitals and
Yeah.
medications and problems and all kinds of other things that they have to, go dig out of the EHR, put into these calculators. Oftentimes they're third-party websites. Sometimes they're not on any website at all, and try and get to some kind of outcome. What's this patient's in hospital mortality, or what's their comorbidity for stroke, or what's their some piece of information that's going to help them treat their patient or make a decision. And
Right.
what Dr. Robinson realized was that these scores living outside of the EHR was just it was a time killer for his workflow. It was just sucking up all of his documentation time, and it was making it super hard for him to apply these, to practice evidence-based medicine the way that he really wanted to practice it. And so he's like, well, these just need to integrate. And so he started looking at how to do that. And he has a knack for just figuring stuff out. And he got really far before before he and I connected. And he was doing things all the right way too. He's using all the right standards, and he's integrating in all the right places. And I said, hey, I can help you do this. And so came on, and we started working out together. And what we've done is built a tool that can look at the chart of the patient, look at the patient's chart and make some initial guesses, some good educated guesses about, hey, based on this patient's problems and their vitals and their current situation, here's a set of risk scores that look highly applicable, right?
Right.
And once we've identified those calculators that look highly applicable to the patient, we can also go look into the EHR and say, hey, by the way, we can also say, here's the data elements that match with the inputs to these calculators. We'll just pull it over for you automatically, right? And that's beautiful, because then the physicians who, they get a small, focused, curated list of calculators that apply to this patient, that then they can say, all right, rather than considering 700 calculators, they can consider 5, or 3, and they might only need 1 or 2, right? And that's great. That's totally fine. It's all in there. They can go look at the one they want to look at. And, some of those we might not be able to pull all the values over, but they might open it up and it says, clinical assessment required. They pull it open, and maybe, we've been able to pull over 2/3 of them. The things that aren't in the EHR that we can't pull over are things that only the doctor would know anyway. Right. And so then it's just a couple of quick answers that they know right off the top of their head, and boom, they have their assessment, and then they're able to go treat their patient. And many of these are super valuable, not just to the doctor and to the way they treat the patient, but also to hospitals, right? Because these things are around, should this patient be hospitalized, or can this patient be treated with outpatient care? What's their risk of a major bleed or a in hospital mortality or something like that, right? And that has, those things have major implications for how hospitals get charged.
I know readmission rates are so huge, coming from the hospital side. So being able to, for the hospitals to be able to kind of look at those dynamic risk scores, and that's massive. I know you briefly spoke on it when we were answering earlier. Recently, I know we've seen a real exponential increase on cyber attacks, especially in the healthcare industry. How does AI Medica kind of ensure that all the data that it compiles and that it can help transfer, how is that safe? How is that secure?
That's a good question. I really should have my chief technology officer on here to tell you all about that. But I can tell you from a high level, without getting really deep into the weeds here, definitely, that so there's a piece of reading here that I wish everybody in health technology would read. And it's not really it's not a book or an article. It's actually kind of it's a funny piece of material, because it was written by a guy who worked at Amazon and he worked at Google, 5 years at both places, and he wrote an internal memo while he was at Google detailing the things that big data was doing well at Amazon and that Google wasn't doing very well at the time he was there. And then he posted it on the Google Circles platform, which was kind of part of his point, was to say that this platform isn't working very well. And he thought it was going to be a private communication to Google, and it actually posted publicly and went viral, right? And so he thought for sure he was going to be fired. I think in a lot of ways it actually kind of like elevated his career in an interesting way, but and he wasn't fired, and he was exactly right. And his point, probably, his name is Steve Yege, and if you just Google Steve Yege's rant, you'll probably find it. It's posted on GitHub somewhere. It's kind of this like revered document in the developer community. It's sort of funny, but he
manifesto.
Among many things he said that were brilliant, one of the things he said that I've held on to and has really changed the way that I think about security is he describes the tension that exists between security and access. And these things are always in contention with each other, right? And that makes sense. Like you're trying to find a safe way for people to access data, but keep it secure. Make sure only the right people access it, right? And anytime you open up a door, to data, there's the potential for it to get hacked or misused. And so the result is a lot of these healthcare companies who rightfully are terrified of consequences of having data breaches, right? They slam that door, right?
Yeah, they do.
Nobody can access, or a very, very, very restricted set can access. And what's really interesting about that, and he makes this argument, is like, look, it's possible to have, now, this isn't the way that healthcare should do it, but he says it's possible to have a low security, high access technology and still have a product. And he names Sony PlayStation Network as a reasonable example, and it's true. You get on the Sony PlayStation Network for 5 minutes, and you run the risk of downloading a virus. So but it's still a network, and tons of people still play, and you've got a product there. That's not a model for healthcare. Don't anybody take my words here and twist them the wrong way. I'm not advocating for that, but his point is that you can have low security and a product. But if you dial security to 100%, you have no product. There is no successful anything out there that's ratcheted security all the way to the top, and because that necessarily dials access all the way to zero, right? And so the point that he makes is that what we really need to do is we need to adopt best practices of technology around security and access, so that A, we can have a product, but B, so we can have good security. And his real argument that's brilliant is that if you provide good access, right, if you're really thinking about access and doing best practices around how you provide access to your data, you'll actually have better security than if you don't. And that's what we see in healthcare. Right now, access is dialed close to zero. Security is dialed all the way to the top. And we have more breaches a year, every year, over a year than ever. And there's several research articles that you don't have to look very far to find it. Those graphs are exponential. They look like this. Last time I checked, they had data up through like 21 or something, or through 22. I'm sure it's more now, but they had the year that I checked there, which was like 2021 or 2022, the number of breaches of 500 or more records per year was like twice a day. Yeah. Which is insane to think about, right? I mean, you can imagine the financial sector if you had that many breaches every year of, like if your bank was like, yeah, we have 500 or more clients have their bank accounts compromised twice a day, every day of the year. You'd be like, I'd like to make an immediate withdrawal.
Yeah.
And so, this idea that we can't have access to healthcare data is totally a lie. And it's completely, it's clearly fomented by people who benefit from holding the data really close.
Yeah.
So at AI Medica, we're all about adopting those highly accepted and highly effective mechanisms of data access that provide the security that ultimately healthcare really needs. And we can, we have to go through significant, very stringent reviews and audits from a security standpoint before we install into a hospital system. And we've installed with some pretty security conscious groups. We're very very careful about how we handle our data.
Yeah, there's definitely always that fine line of just what you spoke to, of being able to keep the access to be able to be innovative and to be able to share and to be able to grow, but then also keep yourself safe. So I love that. That's a focus of AI Medica as well. So kind of jumping back to patients and providers and kind of what AI Medica looks like to the patients and the providers. I know in your work, the emphasis for you guys is definitely on actionable results and improving patient outcomes. So how does these evidence-based results kind of improve the quality compliance and enhance physician workflow efficiency? What are some of the high-level points that help the efficiency and patient outcomes?
Well, an immediate reality is that doctors are spending 50% of their time in the EHR strictly documenting. And, when you're trying to do, when you're
cutting out a huge portion of their day.
Yeah, it's an enormous amount of time that there's, and mostly on tasks that can be automated that they shouldn't be spending their time on anyway. But you think about how much time they have to spend doing some of these things that really are not, it's nothing they go to school for. They don't go to school to learn how to document a patient chart to optimize it for an insurance reimbursement or anything like that. I mean, there's whole teams and departments of hospitals are sort of dedicated to that, but they still expect doctors to do way more in that department than they ever signed up for or ever should be expected to do. That's just not their role.
Expertise.
Yeah, exactly. And so a huge part of this is, they're so tied up with that stuff that then you throw, oh, hey, by the way, we have this exploding body of evidence that suggests you should be treating your patients in all these different ways. You're talking about thousands of resources across thousands of patients across a doctor, per week or month or whatever the time. I mean, and then you think about all the data that goes into those calculators, and it's exponential, right? 700 calculators, and then the data that it depends on is many, many more data inputs, right? And doctors are responsible for every single one of those inputs. And so the reality is that doctors don't do some of this stuff. These evidence-based medicine, evidence-based calculators, risk scores, and things like that. They don't have the time, or they only go out when it's really severe, right? And put, like, the pain has to be really high before they'll be really pushed to go do that. And now we make it we automate it, and we make it almost pleasurable for the physician. That's the other thing. We don't spam doctors either. It's not that, Dr. Robinson, tells me, it's like, there's software that's integrated with my EHR that's been programmed to just turn on and flash in my face every single time I open a patient chart. And he's like, and it's not useful every time. And it drives me nuts. He's like, it's like going to a website and having a bunch of pop-ups jump up at you. You're trying to read an article and you're like, I was in the middle of something. Get out of my way. I'm trying to do something right now. That's not what we want either, right? The last thing that our doctors need is more noise. And so we're creating tools that the doctors actually want to go click the button because they want to see the results of what we're running and what we're doing for them, because we're supporting them and we're helping them be more efficient. We're helping them. So we've seen just organic adoption from our doctors because they love having access to this stuff. This is what they wanted EHRs to be in the first place, which translates to more consistent application of EHR data to treating patients, which is exactly what EHRs were supposed to deliver in the first place, right? Is that the data would flow through algorithms and risk scores that have been validated, which all of the risk scores we implement are from literature or are from studies and efforts that have been done by hospitals, doctors, and researchers, and they want to see that data flow through those algorithms and produce mortality risks and morbidity risks and treatment risks and outcomes and all this stuff, so they can make decisions that benefit their patients.
Yeah, definitely. So, kind of bouncing off that point, could you tell us a little bit more about the learning kind of health system and kind of how that will transform healthcare delivery?
Yeah, the pie in the sky, the dream, to end all dreams. And the learning health system is just this idea that we could get to a point where the data was of such high and sufficient quality, and the algorithms were able to integrate with such ease and and high security that you would be able to feed the outcomes of the hospital's usage of tools and algorithms back into the algorithms. So you get this virtuous loop, right, where you'd be able to be continuously producing new understanding and new linking and new knowledge and new insights into how to do patient care. You'd almost really merge treatment and research in a way, right? It's this idea that you would be able to have technology supplement or support or help the physician and be so effective that the physician is freed up to be able to treat the patient and observe while they're treating the patient, and that we'd be able to collect the outcomes of those decisions that the physicians make, and then apply additional research and algorithms on those outcomes and those inputs to produce additional insights, right? That result in,
Right.
it's this ever incrementally improving care or a delivery of care based on the delivery of care, right? Which right now it all happens isolated in a vacuum, in a box type of thing, and they're not very well coalesced together, and the data is incomplete, and there's lots of holes, lots of missing and distorted pixels, right? And if we tried to do something like that now and put that data through an algorithm, the algorithm is dutifully going to tell us something. We just won't be able to trust it.
Yes, definitely. So, Jordon, I really appreciate you kind of sharing that insight with us and the audience today. Kind of wrapping up, are there any upcoming projects or developments that AI Medica are currently working on that you're allowed or that you could share with the audience to kind of give us maybe a brief kind of sneak peek into the background of AI Medica and what you guys are working on?
Yeah, for sure. So this initial project, or initial product that we've built, these clinical decision support mechanism, delivery mechanism, and automation for physicians. We realized that a lot of people say, "Oh, so you're a calculator company," and it's true. We do have a use case around calculus. We've realized we're not really a calculator company. We're a patient chart review company, and what that really means is we can take that, that's where doctors spend an enormous amount of their time, or struggle to spend a lot of their time, is reviewing patient charts, is being able to see, catch all those esoteric data points and be responsible for those, and understand also the context of those data elements and what they mean in how they treat their patient. And so we realize we have this power to review the patient chart really effectively and efficiently. And now we're trying to apply it to something that physicians are also expected to do, but hate doing even more than documentation in EHR. And that is, they really hate getting these emails on a regular basis from coding departments saying, "Hey, you documented that this patient had this disease. Did you mean this disease?" And they're like, "It's the same disease." "Yeah, but the code's different, and that impacts how the hospital gets paid," right? And the doctor's like, "I don't care, man. I treated this patient several weeks ago or months ago, and I barely remember that day. It was a night shift, and I was going on 40 hours with no sleep, and they're like, give me a break," right? And so there's definitely there's an opportunity there for us to significantly automate that process, so that physicians don't have to think about that stuff. They shouldn't have to think about that stuff, right? And then we can significantly decrease a huge channel of noise that vies for physicians' cognitive space, frees them up then to go do what they want to do, is treat patients, take care of them, right?
That's another thing where, which is it's so almost weird in the healthcare world where they expect doctors, but their expertise is not coding. Those coders, those certified coders, they go to school for that. They just like the doctor does for cardiology, for diabetes, for endocrinology, right? And it's just like
But there's
it's
still
so weird to me that and that's such a big part of the healthcare system. It's
it
coding,
is
billing, and it's such a big impact on the patient that you would think that there would be better checks and balances already in place. So I
But there's an
know that
obvious
that
mismatch.
is, yeah, definitely,
There's
obviously.
such an obvious mismatch there too, because even if you go to school to become a really good medical coder, what you're learning is the combination of codes that bill well.
Codes, right? It's
But you're
not.
still not a doctor. And so
No, you're right.
you still can't take a patient's data and say definitively, yeah, this patient has this
This,
disease.
mhm.
And so it's like it's almost there, but it's not, right? It's a system that's designed to keep the physicians burned, right?
Yeah,
And
yeah.
there's an easy solution to it, and that's what we're trying to do.
So with AI Medica and your expertise, Jordon, in the field, what are some advice or maybe some suggestions that kind of in closing, um, that would kind of that you would give to innovators in the healthcare space, in the informatics space? What are maybe some advice or suggestions you would like to give out?
We need more innovation. We need more
Yeah.
people willing to take that chance. There's a really interesting movement, right? Okay, so we're at the beginning of an S curve here. Data in EHR is only going to become more accessible, not less. The government has passed legislation, and I think will continue to pass legislation that will move towards that end, because it's access to data is going to drive huge financial outcomes for the government and for everybody else abroad. So I think we can continue to expect to see that. The So as data opens up and becomes more accessible, I think there's going to be a huge opportunity for us to optimize EHRs to be what they ultimately should have been all along. I think also that there's tremendous opportunity there. So I would say we need more innovators. We need more people willing to take that plunge. In the past, it's been hard to, because the risk has been perceived to be so high. I think that there is a lot of fear around innovation in healthcare that rightfully exists. It's been a lot of people have been significantly burned, and some very high profile, right? I don't think that a top-down approach is going to solve the issue. That's where a lot of people get really interested. They get really interested in the Amazon and the JP Morgan collaborations, and they get really interested in the Google and these large initiatives that get a lot of press and a lot of attention, but so far have not, it's either publicly failed or have quietly not delivered anything of major, wow, that's transformative. I think that this is going to be very much an innovator's dilemma ground up impact on the industry. I think we're going to see innovation that starts to be able to thrive in this space, that's going to start to redefine what our health technology landscape really looks like. I think that opportunity is on the horizon, and we need to keep pressing forward on that. I would also say too that if we're getting into, there's a tremendous amount of interest. There's a huge movement right now from physicians towards technology and innovation. There are a lot of physicians who are, and it's a good thing and a bad thing, right? On one side, it's like, I'm getting really nervous because a lot of our physicians are so fed up with healthcare. Like, I don't want to be a doctor anymore, right? Which is a bad deal. Look, if the physicians all leave the hospitals, you're gonna, it's no longer a hospital, it's a morgue, right? And so it's like, we've got to have physicians in the hospitals, and
to use these tools, because even if we don't have the doctors in the hospital, all this data and these tools that we're compiling, that we're innovating on, who's going to use them? Who's going to really truly put them to use?
But Bryce, it's worse than that. If we don't have doctors in the hospitals, then the hospitals just become a place where you store dead bodies. Like, we're not. It's true. That's a bad deal, right? And so I think the real point that I'm making there is that on the one hand, we've got physicians who are really disenchanted with this conglomerized version of healthcare and are really struggling. We've got to support them. We've got to give them technology that incentivizes them to stay and helps them treat their patients better. And so that's the con right now is that physicians are trying to leave healthcare. The pro is that most of them are trying to get into some version of technology. They're trying to solve the problem. They're like, look, if you guys aren't going to solve it, we'll come solve it. And it's like, okay, that's good and bad. There's obviously pros and cons here. And obviously AI Medica wouldn't exist if Dr. Robinson hadn't said, all right, I'm going to do something about this, right? And that's fantastic. But my advice there, because I know I get contacted by physicians all the time who are saying, hey, I'm trying to make the jump into technology. Like, how do I do this? How do I think about this? What do I need to go get additional education? Like, how do I, and so some advice there I would say is like, look, be Dr. Robinson. You're the medical, go find the technology partner, because that combination of the right technology partner and the right medical partner equals AI Medica or the equivalent, right? And that's where we've really found a ton of success, is that Adam or Dr. Robinson and I have that combination that's enabling us to take what Adam knows as a doctor, his medical acumen, ability, knowledge, and understanding, and translate it into user experience that physicians really want and need. And the electronic health record system is becoming the vehicle to deploy those changes into healthcare, to ultimately create an environment that physicians don't want to leave, right? And so to the extent that those physicians who are trying to get out of, are like, I don't want to do this anymore, find the right technology partner and figure out what the right problem is to solve, and go solve it, right? And there's never been a better time to integrate into the EHR and push that innovation and create a better world. That's why my goal in all of this is to create a healthcare system and environment that will look better for my children and grandchildren than the one that I'm receiving, right? And the reality is, we're all going to be patients one day. And the state of our healthcare, right? And especially from a technology standpoint, we're all going to end up being cared for and treated by these systems. So let's go make them the very best that we can.
Agree with that. Well, Jordon, it was an absolute pleasure speaking with you. Thank you so much for sharing your insight on the healthcare, technology and also AI Medica's mission to kind of simplify healthcare. It's so fantastic and refreshing to hear about that. I wish you continued success, of course, in driving positive change, patient outcomes, and definitely healthcare efficiency. I can't wait to see what AI Medica does next.
Thanks, Bryce. Thanks for having me on the show.
Yeah, thank you so much. Bye.
See ya. Okay, so now that would stop recording.
Yeah. So that was great. Thank you so much for that, Jordon. I think that was fantastic. I hope that felt good for you.
Mm-hmm.
Definitely.
Very passionate about this stuff. I love talking about it. So thanks for giving me the opportunity.
Yeah, no problem at all. We'll Onkar will be in touch, or I'll be in touch, and we'll send over a recording and let you kind of review it, make sure everything's copacetic on your side, and then we'll get it posted and see what happens. But thank you so much. You're obviously my first guest too, so thank you for kind of helping me break through that barrier. We're excited.
Hey man, somebody's got to be the first.
Yeah. Hope you have a wonderful holidays, and I'll talk to you soon.
Appreciate it. Thanks, Bryce. You too. See you.
You too. Bye.